So today we'll talk about pediatric renal disorders. And your learning objectives for the majority of this PowerPoint is to be able to identify the disorders and the risk factors, describe the nursing action and the education that the nurse would give the families, and of course explain the medications associated with each disorder. At the end of this PowerPoint, we're going to be discussing structural disorders, and mainly it's just so you have a grasp on what they are. Most of them are need surgery to fix them, and they're pretty obvious. They're congenital, most of them. So as far as that goes, I just want you to be able to identify them. Then there's a bunch of vocabulary words, tests that are run in children that you can look up and be able to explain them if need be. So we're going to start with enuresis. Enuresis used to be an umbrella name, and underneath it was nocturnal enuresis, meaning nighttime, like bedwetting, and diurnal enuresis. However, today, most of the time, you're just going to hear the term enuresis, and when you do by itself, they're talking about bedwetting, and so keep that in mind. Sometimes kids will experience bedwetting and wetting their pants during the day, or just one or the other. Some of the studies have showed us that these kids are very heavy sleepers in general, and when they go to bed, whatever's in their bladder will just relax and pour out of them. So as they get older, generally children aren't as heavy of a sleeper, and this issue sometimes just goes away by itself. And we usually wait to age 5 to give the child a diagnosis. The criteria for the diagnosis is that the child must wet the bed 2 times a week for 3 months. So we need to keep track of that and teach the parents. There are 2 types of enuresis. One is primary, which means if we're only talking about bedwetting, the child has never gone to bed without wetting his bed. He's never been free from having those accidents. And then secondary, the child began wetting his bed after having full control, no problems, and now he's wetting his bed. And with that, there's a few different reasons that can happen. But let's look at the risk factors. Most of the time, the child has a family member who also wet his bed. Many times it's the father of the child. It seems to be more prevalent in males to begin with. And if that's the case, generally the parents are a little bit more understanding. And when dad stopped wetting the bed, usually the child will follow the same guidelines. And it's just one of those family history issues that we really don't quite understand. We see it more in boys. We see it in kids that have a lot of bladder disorders. So for instance, the secondary enuresis began wetting bed after having full control. Could be the child now has a UTI and he has no control over wetting the bed. And sometimes that's the case. So these children actually need some testing done prior to determining that this is something that the child has some control over. Sometimes it's emotional factors, problems going on at home or at school, being bullied. Maybe sometimes the child doesn't want to go to daycare and misses his parents. It could be parents are getting divorced or they're arguing. The list could go on, and it's some emotional factors that children face, and one of the things would be regression in that situation. And believe it or not, constipation. Huge studies done on this issue to show us that if a child has frequent bedwetting and he is constipated, we first have to fix the constipation, because the children that are always constipated have enlarged rectums, and the stool will push upon the bladder, and especially if the child's sleeping, they won't be able to control it. So it's very common for children who have a history of constipation issues to be bedwetters. And once the constipation has been rectified, the child generally will stop wetting the bed at the same time. So nursing care includes teaching, of course, and we have to teach the parents and the child. Remember, we want to encourage the parents to be kind about this. It's pretty frustrating when you have a 5, 6, 7-year-old kid. He's wetting the bed every night, and you're a working parent, and every day you're running those sheets through the wash. It's difficult. These children will need to have a shower in the morning instead of at night, like most little kids do. So the nurse should bond with the child and talk to them as a little 5 or 6-year-old, not as a baby, and say, you know what, before you go to bed every night, you need to go into the bathroom and empty your bladder. We're going to talk in a little while about double voiding, but this would be a good time to teach them to double void. Double voiding helps the child totally empty the bladder. So the child goes in the bathroom and urinates, and then he sits there for a few minutes and then pushes again, and more urine will come out. And that's usually the residual urine that is being held up in the bladder. And many times this works so great that the kid doesn't wet his bed. The fluids that the child drinks should be during the day and not after supper hour. We don't want any residual urine in their bladder. And studies have shown that fruit and fruit drinks and caffeine and carbonated drinks, and there's one study that even shows milk, can actually cause a child to wet his bed because a child doesn't feel these particular drinks in the bladder. So they say they don't have to go, they go to bed and they, have all this stuff in their bladder and they wet the bed. So ideally the children wouldn't drink any of these liquids after 2 or 4 o'clock. Talking with the parents, positive reinforcement is the only thing that's going to work in this situation. Many times the children are already upset about it. So no diapers and no disciplining the child. Many times, as I said, they're heavy sleepers and they have no control over it. A calendar of wet and dry days, number 1, will help actually get our diagnosis 2 times a week for 3 months. But also it shows the child that he does have dry days. And together, the parent and the child can analyze, like, how come this night was dry and this night wasn't dry? And they could actually come up with a plan. The pathway to the bathroom needs to be lit up so they're not afraid to go to the bathroom. And it needs to be clear so the child doesn't fall or isn't afraid of something. During the day, we need to teach the children and the nurses, right, not to hold their urine during the day. Sometimes they're in school and they don't want to go to the bathroom. And so they hold it, and they're stretching their bladder out. So at night, their bladder's full of urine because it's stretched out so it can hold more, and then they wet the bed. Psychologists tell us that these children should change their own linens and pajamas themselves because it helps them own their problem, and it'll encourage them to seek treatment and to follow through with treatments. The child should have that high fiber diet to avoid the constipation issue. Parents can feel free to wake the child up at night. Generally 2 hours after they go to bed, most children have already urinated. So that's the ideal time to wake them up. If the physician gives them medications to help them through this process, as the nurse will explain the medications, the side effects, and how to give them. And always be supportive. The nurse needs to evaluate the child's and the family coping skills. Sometimes people come in very, very angry about this happening. They don't understand the situation the child is in. We need to find out how they cope with other problems that maybe aren't quite as serious either, and see if we can guide them through this. The child's self-esteem might have already been damaged, but we need to tell them that this happens all the time, and probably more than their parents even realize. and you need to be a support for this child. Some of the causes are a small bladder. They can't hold as much urine, and so even just a sip of water, once they go to sleep, the muscles relax, they may pee their bed. Persistent UTIs, stress, emotional trauma, sometimes developmental delays that interfere with toilet training. Sometimes it's just the child themselves. Too much fluid intake in the evening, chronic illness where they are in bed all the time, and either another family member has had the same issue, or this is a child that sleeps very sound. So the treatment for it, the number one treatment still today are these alarms. And I kind of tried to put some pictures there so you could see it. They actually, as soon as the little pad under the child, or if they use the one that goes into the pajamas, as soon as they get just a touch of urine, just a dribble, the alarm goes off and wakes the child up. And that way the child can run to the bathroom and finish urinating into the bathroom. This is the most effective treatment, and it works over and over. So generally, after some tests have been done to make sure there's not a UTI, see if there's a problem with the bladder capacity, this would be the first thing that would be tried. The second thing would be bladder training. So what the child does is they have regular scheduled trips throughout the whole day to the bathroom. And what it does is that during the day, if the child has a small bladder or is used to running to the bathroom during the day and empty their bladder, and they can't do that at night, of course, this teaches them that, okay, wait, you have another half hour till you can go to the bathroom, can you hold it? And it kind of stretches the bladder for the child. Bladder training is typically used as part of an enuresis treatment program, and it works a lot. There are some medicines, if these are tried it for a reasonable length of time and are not successful, there are 3 different types or categories of medications that are given. One is an antidiuretic hormone, and I believe the second one is a tricyclerate, and the third one is an anticholinergic. I have it here, I do. So the antidiuretic hormone is the desmopressin, and it can be also a nasal spray. However, the nasal spray has not been very effective, but taking the pill does. It reduces the volume of urine, and this is given to the child at bedtime. The parents need to be taught to administer it right at bedtime, and they need to also be taught any adverse reactions to it. We also encourage the family to restrict the child's fluid intake after dinner in order for this to be successful. The next one is the tricyclerate antidepressant, because it inhibits urination. And this drug, the child needs to be monitored for suicidal tendencies. And the parents need to monitor for therapeutic effectiveness. The length of treatment that it needs to be tried is 6 to 8 weeks. And if it's not working, they need to be weaned off of it gradually. This needs to be given with food. So generally, this particular drug is given at the supper hour. And the last but not least is the anticholinergic. It reduces the bladder contractions. And so the parents need to be taught that, I'm looking for my notes here, I lost them for a second, that they need to monitor it to see how effective it is. And we need to tell them that sometimes these kids will actually have dry mouths with this and will want to drink more water, which is not really what we want them to do. So we need to warn them about that. So complications for enuresis training is emotional problems. The child already might have a poor self-esteem, and if he's not effective with any of these drugs or treatments, they may actually start feeling worse about themselves. Nursing diagnosis could be altered body image, social isolation, and fears. It's really hard, 5, 6, 7 is the age where kids start doing sleepovers and camping out, and this could really make a child not want to, be part of that social life. When nothing has worked, and sometimes that's what we deal with, most children will outgrow the disorder by the time they're a teenager. So that would be probably the one thing you can tell the child, that this eventually will go away. So a UTI, or a urinary tract infection. On the left, you'll see some terms that would be really wise that you know about it. For instance, the pyelonephritis is an inflammation of the upper urinary tract and the kidneys. If a boy gets a urinary tract infection, and we're talking children, it's probably going to be pyelonephritis. And pyelonephritis is one of the more serious ones. Boys tend to have longer ureters. Therefore, they very seldom have UTIs, where girls with the shorters do. So if the boy gets it, it's going to be high up and in the upper urinary tract and the kidneys. So it'll be pyelonephritis. Cystitis is an inflammation of the bladder. Urethritis is an inflammation of the urethra. Recurrent UTI is, do I have it written down? Is a UTI, okay, here it is multiple occurrences of bacteria or symptomatic bacteria. Recurrent UTI. Persistent is unsolved bacteria with antibiotic therapy. So if the kid comes in with a UTI and doesn't get better, he needs to go see a pediatric urologist. One thing you should know is that children really shouldn't have urinary tract infections. And there's some things that cause it, which we'll talk about. Once this is discussed with the families, we don't expect to see urinary tract infections anymore. If the child has the one and it's caused from one of the risk factors, but then they have a second one, generally they'll get their antibiotics and get cleared up, and they'll have to go to a pediatric urologist for testing to see why this child has 2 UTIs. They're not very common in little children, and they shouldn't be seen so often. So for instance, a boy with pyelonephritis, he has that one, and maybe for some reason it's one of the risk factors at the right, but he should not get another one. That needs to be fixed, and he should not get another one. The same thing with the child with cystitis. So recurrent means it keeps coming back, which is bad. Persistent means they're given antibiotics and it never goes away. And then bacteriuria means just bacteria in the urine. Sometimes the kids will have a febrile UTI, and that means not only are they symptomatic, but they actually also have a fever, and that's all that one means. And the urosepsis. The urosepsis is just what we call a bacterial illness. Sometimes some risk factors can be urinary stasis. That can be if urine is sitting around in that bladder way too long. It can be for a child that needs to be straight cathetered, isn't being straight cath regularly, such as a spinal bifida child, or a child that refuses to run to the bathroom and they're holding their urine too long. Sometimes kids have some urinary tract anomalies that aren't seen before they're born, and they keep having these UTIs. I had a kid that had a third ureter, and it was backing up and refluxing back up. And once the child had the surgery, no more problems. Sometimes it is reflux, where the urine gets all the way down to the bladder to be expelled, and one of the little flaps on the ureters doesn't close, so the urine backs up. Catheters, those are the kids that need to be cathed frequently. Constipation. Once again, constipation is an issue here. Remember, constipation occurs when stool remains too long in the colon or the stool moves too slowly in the colon. As the stool remains in the colon, fluid is reabsorbed by the body. The longer the stool remains, the more fluid is reabsorbed. This can make the stool hard and small. And this stool remains in the colon, more stool will accumulate, and then the child will have very large stools. And the accumulation of stool can then cause the colon to stretch, which then causes the stool to move even slower through the colon and makes the problem worse. Many signs constipation is almost always in little children caused by them holding back their stool. A common reason child would do this is out of fear of having a fear of stooling, like they don't want to go to the bathroom during preschool or whatever. And because they're holding it back, then when they do go, it's painful. So the next time they have to go again, they don't want to because they don't want it to hurt. It's a problem that goes on and on. Sometimes young children, like adolescents, become constipated because of poor diet, but generally that would be an adolescent. We don't see it as often. So there's a close relationship between the muscles and nerves that control the bladder functions and those that control bowel movements. The bladder and the colon are so close together in the body that the large amount of stool in the colon can put pressure on the bladder, which can cause the bladder not to fill as much as it should or contract when the bladder may cause the bladder to contract when we don't want the bladder to contract. The large amount of stool can also cause the bladder not to empty well. All of this can lead to daytime wetting, nighttime wetting, and urinary tract infections. So one of the questions when a parent comes in and the child has symptoms of a urinary tract infection is, when was the last time the kid pooped? We need to keep track of that. Onset of toilet training. Sometimes it's a psychological thing, although that can't really be proven. But if the child's potty trained kind of young, and then they get older, they hold their urine then. They're not emotionally mature to be potty trained. Uncircumcised males that aren't cleaned well. Females have a lot more urinary tract infections than males because the urethra is very close to the rectum, and when they clean themselves after having a bowel movement, instead of going front to back, they may go back to front and push some E. coli up their urethra up to their ureters. Sometimes kids that wear tight synthetic underwear or they sit around in wet bathing suits can develop a UTI. Bubble baths are known for developing UTI, as pinworms are. I had the beginning of toilet training twice here. And then sexual activity. We have to teach our teenagers that after they've had sexual activity to go to the bathroom and void and get anything impure out of their urethra. So manifestations in infants are slightly different than in children, but generally the baby will be very irritable and cry. They'll cry a lot. And, the book says when they're urinating. However, it's kind of hard to tell when a baby's urinating. They'll definitely have a fever, and some kids will have vomiting and diarrhea along with it, some other viral signs. They're poor feeders, and occasionally there'll be some hematuria. I put a little mark there. It's about newborns for those of you that think that may be where you're going. And this little thing about fever or hypothermia, this is kids that haven't left the hospital yet that are very newborn. So it's just a little FYI for those of you that are interested in taking care of the newborn baby. The children's manifestation is similar, but they can talk usually. So they'll tell you they have abdominal, flank, or back pain. Dysuria means pain when they urinate, and usually the urine is foul smelling. Hematuria could be present. And in a child that's normally toilet trained, they'll start having accidents because they'll start dribbling. Fever with the flat pain and abdominal pain is really a sign of polynephritis, which we talked about a little earlier. Every now and then we'll have a child that doesn't have a lot of symptoms, but will be complaining of a stomach ache, gastro symptoms, respiratory symptoms, kind of unusual. I'm not really sure how the respiratory has to do with it, but the gastro, sometimes kids are pretty tough. And the first thing is abdominal pain, and they'll complain about that. The urine itself will be thick and cloudy and have some mucus strains if you look at it. The child will have pyuria, and once we do the urine CNS, we'll see bacterial growth. So in this picture, you can see like a little plastic baggie, got a little white circle on it that's sticky. And we can use this for kids that are in potty train or infants to get a UA. It's if it's a little boy, the penis and the scrotum is put inside that little hole where the white is, and then it's stuck onto the peritoneum. And then when the baby urinates, we take it off, and we can dip the urine and see if they are showing signs of a UTI, such as white cells, strands of particles. If it's a little girl, the urethra opening needs to be right where that little hole is. So these aren't like the most pleasant things for the baby. They're sticky, they stick on, and you whip it off and they get red. But it's really the only way to do a UA to see if this baby possibly could have a urine CNS, a urinary tract infection. Remember, the infants can't talk. They'll cry hysterically and have a fever. And we want to make sure we're not dealing with something like meningitis. So this is a quick way to kind of say, yeah, it's probably a UTI. There are sterile little bags. They're not used any longer because they have found that by putting these little bags on the kids, they're contaminated. So they're not very helpful. So instead, a child who is not potty trained will need to be straight cath to get that urine CNS. After a child has had one or two UTIs, depending on the physician's protocol, they'll have some other procedures done. The renography, or actually the renal ultrasound, is done, and they're looking for structural anomalies or vascular issues. A VCUG is done where they actually put a catheter into the child and inject contrasting material into the bladder till the bladder's full. Then they'll take some pictures of the bladder and the kidneys and the urethra. And then they will, the child will eliminate the contrast by either urinating or they'll leave the Foley in for a little while till all the contrast comes out. The IVP isn't done too much any longer with children with CT scans and the voiding cysto, but what they would do is actually inject the dye through an IV into the child instead of using the voiding cysto, and watch it as it goes through the system, and then it's eliminated. And then the last one there, the GMSA, is looking really for renal scarring. So once again, through the IV, the child will get some kind of radioactive contrast that can be filtered by the glomeruli and excreted in the urine. During the filtration phase, photographs or imaging is done to evaluate the kidneys itself to see if there's any anatomical structures that are incorrect, or to see if something's pressing against the kidneys. So if a child comes in with a possible urinary tract infection and it's early in the morning, ideally get a UA from them. We need a urine CNS. So for babies, we wash them very well and then we stray cath them. For little kids, we actually wash them. I know you use betadine with older children, with adults, but we actually use soap and water with our little children. And then we have them urinate into a sterile cup. Sometimes they'll do a suprapubic aspiration, especially if the child can't void. That reduces the risk of an infection from us putting a catheter into the child. And we can, tap the bladder there and get some urine and do a urine CNS that way. If the child's admitted, we want to push fluids and encourage frequent urination and total emptying of the bladder. So take the child to the bathroom frequently. They need to be on I&O. They can have pain medicine. And because we always worry about that constipation, we encourage a high fiber diet. When they're being discharged, we need to go over the steps on how to wipe a female from front to back. And we need to teach our children how to double void. This really will empty all the urine in the bladder. So we have the child sit and go potty and urinate. We have them stop upon, just about before they're done. We sit there, sing a song, count, do whatever. And then in a few minutes, we have them urinate again. And that will actually empty their bladder totally. We talk to the family and the child about cotton underwear, and it shouldn't be too tight. And if, the child wets its pants, they need to be changed immediately. Unfortunately, bedwetting and wetting their pants is sometimes very frustrating to some parents. And they're kind of hard on a kid, and they might have them sitting in wet clothing for a long time. If a child is playing in a pool, when they get out, there should be a dry swimsuit that they can change into. If it's a little boy, we want to teach the parents once again how to clean that foreskin if the child is not circumcised. They might have been taught initially, being uncomfortable with it, but this scare of a UTI sometimes will help them go ahead and take care of the child better. All little children should not have bubble baths, whirlpools, or hot tubs. UTIs are known to follow. In fact, we like when children shower instead of bathing. However, if the child takes a tub bath and they like to play in the water, which is a typical little kid thing to do, they should play in the water first, then get washed and the hair shampooed and get right out. Not wash, shampooed, and then they play, because then they're sitting in soapy water. We have to remind the family and the child if old enough, it's really important to drink a lot of fluids. And if the child is older and is sexually active, we need to remind them to avoid after having sex. And the older child, the younger child, the parents all need to understand that the child needs to take all of the antibiotic until it's gone. So now we're going to talk about acute glomerulonephritis. We're talking about acute, but I want you to know that there's two types, acute and chronic. Chronic is something that comes up slowly over a period of time and damages the tissues, where acute comes up quickly and damages the tissues. So acute. Another way that it might be said instead of acute glomerulonephritis is acute post-streptococcal glomerulonephritis. And the initials for that is APSGN. Okay, and that's what most commonly causes this. But it's an inflammation of the glomerule, the little bundles of vessels that are inside the kidney that is used to filter the waste products. And now they're swollen and they can't filter the waste products and they can't make urine. So the kidneys, back up and become enlarged, fatty, and congested. Generally, this is considered a post-infectious disorder. It can be associated with pneumococcal, streptococcal, and viral infections. We're going to talk mostly about streptococcal because that's like the number one cause. Remember, though, there's a vaccine for pneumococcal, just so that you know it. It's also considered an immune disease, an autoimmune disease, because the immune system overreacts to the infection and causes, the swelling and the inflammation of the glomeruli. So acute post-streptococcal glomerulonephritis is an antibody versus antigen disease that occurs as a result of certain strains of the group A B hemolytic streptococcal infection and is most commonly seen in children between the ages of 5 and 8. They generally, even though I have all this other stuff over on the right, will present with oliguria, edema, hypertension, circulatory congestion, hematuria, and some proteinuria. It's a pretty serious thing. Generally, the children will have recent upper respiratory infection or a strep infection. So what do we see with these kids? Well, their urine is, there's different words for this. Cloudy isn't the best word, but cloudy is used. Tea-colored urine, smoky, cola-colored urine. Remember, when anything's brown, like vomitus or urine, it's probably old blood. We see a decreased urine output, an irritability, and the child looks very sick. They're lethargic and they don't want to eat. They're very anorexic. They'll have some vague reports of abdominal discomfort, headaches, and dysuria. In the morning when they get up, they'll have periorbital edema. That's what frightens the family first. It's worse in the morning, and then it spreads to the abdomen and lower extremities, and they'll always have facial edema. Once again, it's worse in the morning, but spreads to the abdomen, and it progresses downward throughout the day. We see mild to severe hypertension. They have azotemia, and with that, if you drew their blood, you'd have to do that. There'd be nitrogen in their blood. It's different than your uremia. I have a lot of students confuse the two. The uremia has urea in the blood. This has nitrogen in the blood. Okay. Generally, they'll draw some streptozine titers, and they will have elevated streptococcal antibodies titers. They'll have a decreased glomerular filtration rate. Remember, it can't work. They'll have decreased serum complement levels, but they will return to normal, a week to 2 weeks after the disease. Initially, they'll be hyperkalemic, hyperphosphatemia, they'll be acidotic, and hypokalemia. During this edema phase, their heart will be enlarged, they'll have pulmonary congestion, and pleural effusions. So lab tests that are done is usually a throat culture to identify possible strep infection, and it's usually the #1 cause. A UA will be done, and we'll look at smoky proteinuria urine with an increased specific gravity. Renal function studies will be done, and we'll see an elevated BUN and creatinine because they're not peeing properly. The anti-streptozine O titer will be done, and we'll see that it's positive. Serum complement decreases initially, and then it increases as recovery takes place. It'll return to normal in 8 to 10 weeks. And they'll also do electrolytes and a chest x-ray to make sure nothing else is going on with the child. So therapeutic procedures, if the child has decreased urine output, or if their glomerular filtration rate is very decreased, They will restrict fluids and sodium. They very often do this in children, but they will in this situation. The child will usually be put on diuretics and antihypertensive drugs. Okay, so as long as they're in the hospital, we'll do daily weights and accurate INOs. We're actually going to encourage them to move around and get that edema moving. We'll monitor their vital signs. We'll watch for loss of consciousness and a change in their behaviors. Sometimes neurological status changes during this time. We'll have to actually use seizure precautions at the bedside. Most of the time right now, their diet would limit sodium, but if oliguria, they'll limit potassium. If there's severe asthmatemia, they'll limit protein, and they'll get a dietary consult. If fluids are restricted, this is the hardest thing with the child. You as the nurse has to sit down and evenly divide the amount of fluids for while the child is awake and use small cups. So you'll want to divide it up to morning, afternoon, and evening, and maybe leave a half an ounce or something for during the night. And that's all they can have. You give them a small cup. You fill up exactly how much they can have for the morning, and you tell them that. Monitor their skin. Elevate anything that's edematous. And if they're in bed, you're going to have to frequently reposition. If they're not, you'll want to encourage activity. You want to look for skin breakdown, which happens kind of often. And you want to be careful about their bony prominences and use a specialty mattress. For discharge, you want to discuss the dietary restrictions with the family. Make sure they understand it and the reasons behind it. You're going to want to teach the fluid restrictions. You're going to want to encourage activity, but instruct the families to allow the child to rest. You'll want to show them ways to prevent infection, such as, hand washing, ways for the little girls to wipe front to back, ways to take care of an uncircumcised penis. You want to, this is most important, teach them the importance of follow-up care. A lot of these people, the child is admitted, they get better, they go home, and then they're not seen for a long time. While the child is in the hospital, or even if they go home and they're going to be, kind of lying around a lot, you want to teach the child and the family how to turn, cough, and deep breathe. You will want to teach the family how to monitor their vital signs, but mainly their temperature. Teach good hand washing. Teach about completing all the antibiotic therapy, and provide emotional support. These kids are exhausted. Look at one of their symptoms on the other side, lethargy. So they need frequent rest periods, but activity is also important for them, and it should be age appropriate to get their mind off of the situation. So we'll talk about minimal change nephrotic syndrome. Nephrotic syndrome is where the glomeruli that's filtering for your kidney is damaged, and too much protein slips through the filters into the urine. Both adults and children can get it, but the children usually have minimal change disease. Doctors don't know why this disease stops the kidneys from working properly, but the kidney tissue from the children with this disease looks relatively normal under a microscope, hence the name minimal change disease. So some risk factors is that we usually see it in the ages between 2 and 3. It affects more boys and girls. It is usually preceded by a viral upper respiratory infection. And that's about all we know on those risk factors. When we see these kids, generally speaking, they will have gained weight over the period of days or weeks. And in the morning, they'll have the facial and the periorbital edema, and it gets a little bit better as the day goes on. The one thing that's a little different about these kids is their swollen abdomen that actually is ascites, and they look like little kids with cirrhosis of the liver. So their abdomen, their genitalia, and their lower extremities swell up during the day. They complain about anorexia, diarrhea, irritability, and lethargy. Interesting enough, their urine is frothy, and where our glomerulonephritis people had our cola-colored urine. These kids have frothy urine, and whenever there's frothy urine, always dip it for protein. It's like a really big sign that there's probably protein in it. Their blood pressure usually is okay, and their nail beds develop these white lines in it. And unfortunately, these kids become and increases susceptible to infection. So the labs on the right are what's usually drawn. Interesting enough, the protein in the urine and sometimes a biopsy is what diagnoses these kids more than anything else. So look at their lab results expected on the right. So we know they're going to have hypoalbuminemia because albumin is protein and they're peeing it out. Interesting enough, they have high fat and cholesterol levels in the blood, and because their body doesn't have the albumin, there's room now for the fat to accumulate. And they say that sometimes we need to think of it as the fat is clogging up the arteries. So they'll have hypercholesterol. In their urine, we'll have a lot of protein and a high specific gravity and Highland casts. Their platelet level is usually high. And let me read. I actually kind of wrote why that happens. And, because they lose so much protein from the blood, that affects the body's ability to prevent blood clots. So they'll have increased platelets, and we actually have to watch these kids for blood clots. They'll have hyponatremia because as they pee out the protein, their sodium's following it, and they'll have hypocalcium levels. And I want to get back to one more thing. I said before that they're at risk for infections, and let me explain that. I meant to explain it then. The infections like a pneumonia or a meningitis can occur because the body loses the infection proteins called immunoglobulins. Those are proteins and they're peeing those out. Now, in some books, if you look carefully, it'll say that these kids will have high blood pressure. So it needs to be watched either way. Your book says it's usually normal to low, but as a nurse, you're going to monitor the edema, I&O. You'll check that urine for protein with a urine dipstick, and you'll do daily weights. The environment should be kind of quiet for these kids. Monitor their skin integrity if they are on bed rest so that they don't get any pressure sores, and check their vitals. as I just explained, to protect these children from people who have infections, and the dietitian should visit them for a low sodium diet. Once again, the edematous part should be elevated. It's interesting, these kids are very sick, and this is a very risky disease. But once the edema improves, the children feel great and they resume normal activity. Teaching the family how to take care of the child, or even while they're in the hospital, you're going to show them when you dip the urine for protein so they know how to do that at home. Because an increase in protein in the urine is what they're going to see if the child is relapsing. The child needs to be on a low sodium diet, and the family has to understand that. The child will be given medications, which we'll go over in a minute. And, we have to prevent feelings of isolation for the child. They might feel all alone. So medications will be the corticosteroids, the immunosuppressants, diuretics, antibiotics, sometimes hypertensives, and they have to keep up with their vaccinations, but while they're ill, they cannot have their live vaccination. And once again, sodium restrictive diet. So they will be given some corticosteroids, and you know that prednisone is usually number one. If kids can't tolerate it, they can do the cyclophosphamides, but we generally will do prednisone, okay? And this will induce, brings down the inflammation, and it'll reduce remission. The children will need diuretics to get rid of the edema, and they usually use furosemide. We want to increase plasma proteins and decrease the edema. So by putting albumin back into the bloodstream, the edema will decrease. So usually they receive 25% IV albumin. Complications for these kids is sepsis and infection. A couple of different reasons. One, we explained, their immune system is low. Also, they are on corticosteroids. Circulation inefficiency. We worry about blood clots forming. They have a high cholesterol level. And so circulation insufficiency is a real thing that can happen, and thromboembolisms. For discharge teaching, once again, it'll be dietary management, adequate rest. Once again, people need to be encouraged with follow-up care. I'm going to tell you, I always used to take students to the all children's outpatient clinics, and what we found is even though there might be 15 children scheduled, you'll see 3, because the people don't keep their appointments when their children feel good. We want to reduce infection, and we want to reduce the risks of it with the immunizations and teaching good hand washing. We're going to monitor that blood pressure and that protein in the urine. Explain relapses and the complications of it. And that's one of the easiest way the parents can tell at home is, weighing the child and monitoring that protein in the urine, and they need support. So hemolytic uremic syndrome, another term is HUS, is when the body damages red blood cells from an outside source, an outside infection, and it blocks the kidney's filtering system, and it leads to kidney failure in children. Generally, we see it after the children have had strains of E. coli bacteria. They begin with bloody diarrhea and vomiting. They get the E. coli from contaminated foods such as meat and dairies, undercooked hamburger meat. It can be found in contaminated water at pools and water parks. And we've seen outbreaks in daycares, water parks, and mostly in the summer. So the child, this is a very serious illness, and the children are very, very sick. As you can see at the top, it says a triad of symptoms, a microangiopathic hemolytic anemia, thrombocytopenia, and AKI, which is after an infection or a recent illness, after a known infection or recent illness. The risk factors are kids between 6 months and 3 years. Some books will say up to 5 years. And these kids have ingested the toxin that produces E. coli. Sometimes we see some genetic disorders are more prone to this. And the toxin in the blood stream is killing red blood cells or squashing them. So manifestations, the child will come to the hospital with bloody diarrhea and edema. They will not avoid it, or if they have, it's very little. They'll be hypertensive and many times have seizures. They'll have a poor appetite, irritable, lethargy. Most are pallor, but some are jaundice. And sometimes this has been noted after varicella, measles, or a UTI, but not very rarely, very We usually start off with looking at their lab results, where they, because they are bleeding, bloody diarrhea, they'll have a decreased hemoglobin and hematocrit. Their immune system is trying to click in, so they'll have an elevated retic count. In the urine, we'll see hematuria and proteinuria. They'll have elevated BUN and creatinine levels, and urine fibrins blood products, which leads us to our thrombocytopenia. They'll have high potassium and phosphate, but low sodium and calcium. They'll be in metabolic acidosis. Remember, diarrhea is the predominant symptom. And we'll see some elevated bilirubin. So they start off, these kids are very, very sick, and most of the time end up on dialysis. So we first replace fluids using an isotonic solution. They're losing so much blood, which is fluid, and then transfused, packed RBCs. Accurate INO and daily weights, and they need skin care for their edema. They'll have a lot of abdominal pain, so they can get pain medication for their hypertension, and acidosis and electrolyte balance needs to be monitored. They'll have blood draws frequently. Generally, these kids will be put in seizure precautions and given anti-seizure medications. And if they're not voiding, or if they have seizures, right away they're prepared for either hemodialysis, peritoneal dialysis, or continuous hemofiltration. Once they're starting to feel a little bit better, the diarrhea and vomiting have subsided, enteral nutrition is started, and a week or so after that, if they're doing well, they'll have a high calorie and carbohydrate, no salt and low potassium diet. Teaching, while the child's in the hospital, they need to be taught, as well as, before they go home. And of course, undercooked meats needs to be addressed, and unwashed vegetables, unpasteurized apple juice, and alfalfa sprouts. Avoiding public pools, not giving anti-motility for diarrhea. Get a little blood pressure cuff that the family can take home, and teach how to take blood pressures and how to give the medications. If the child is on hemodialysis or peritoneal dialysis, special skin care is needed and needs to be taught. All of the medications and their side effects and how to take them needs to be taught to the parents. Nutrition restrictions and complications need to be taught. Educate about fluid overload, weights, and INO, follow-up appointments, and support. The actual hemolytic uremic syndrome is diagnosed generally by a urine test first, interesting enough, and then a percutaneous kidney biopsy is the second. Let's see what you need to know. Left untreated, it can lead to kidney failure. It can lead to life-threatening problems. Blood clots can block the small blood vessels and other parts of the body. Blocked intestines, muscle destruction, and swelling of the pancreas could occur. Long-term effects of HOS include blood pressure aneuremia, too much nitrogen in the blood, will be there forever. I did want to say one more thing and I can't find it. One of the questions that someone had asked me at some point, and let me just, I think I might have said it, let me just in case. HUS occurs when a toxic substance is released into the bloodstream and destroys the red blood cells. This causes bleeding, that's where the petechiae comes from, and the purpura, blood clots, and kidney damage. So we're going to just talk briefly about some structures or structure disorders in the child with renal issues. So we're going to talk about obstructive defects or uropathy. And hydronephrosis is a swelling of one or both of the kidneys. It happens when urine can't drain from a kidney and it builds up in the kidney as a result. It can occur from blockage in the tubes that drain urine from the kidneys, the ureters, or from an anatomical defect that doesn't allow urine to drain properly. The true name for this is hydronephrosis, and it can happen at any age. Hydronephrosis in children can be diagnosed during infancy or even sometimes during a prenatal ultrasound before the baby is born. It doesn't always cause symptoms. When they occur, signs and symptoms could be a pain in the side and back, the flank pain, and it can actually travel to the lower abdomen or groin. Urinary problems such as pain with urination or feeling an urgent or frequent need to urinate, nausea and vomiting, fever, and failure to thrive in the infant. So it depends on how much the blockage is how much symptoms that we're going to see. It can be diagnosed with a blood test, a urine test, an ultrasound, and avoiding cysto. So what you really need to know about this is mild to moderate hydronephrosis could actually resolve on its own. Sometimes they'll give the children antibiotic therapy to lower the risk of urinary tract infections from the urine backing up so much. But the severe one makes it hard for the kidney to function. And so most of the time this involves some kind of a reflux. So surgery may be recommended to eliminate the blockage or correct the reflux. So hydronephrosis is an obstructive defect or uropathy, and it causes urine to back up around the kidneys. It's just a condition. Mild or moderate could probably be okay and go away by itself, but severe won't and may need surgery. So an epispadias is where the urethral opening is on the dorsal aspect of the penis. So when the baby's born and they go to circumcise them, they'll usually notice that the urethral opening's in the wrong place and they won't circumcise the child at that point. They watch the baby to see if they can urinate all right. Generally speaking, they can't. The urine will go straight up in the air. And that will also be a problem later on in life when they want to impregnate a woman. So generally this will be repaired. It'll be repaired somewhere between 3 and 6 months. And the hypospadias is just the opposite. The urethral opening is on the ventricle or the lower aspect of the penis. And the same thing, neither one of these kids will be circumcised until this is corrected. Oh, and in this picture it shows the scrotum. Sometimes it can be as low as the scrotum. Hydrocele is a collection of fluid in the scrotal sac. It usually doesn't bother the baby, and it does not get larger when the baby cries. It can feel tense. It's not retractable. And generally, this will go away by the time the baby's a year old. If we hold a flashlight to the scrotum, you can see the fluid in there. Most of the time, it goes away by itself. So the first picture is a picture of a inguinal hernia. I'm sorry, I lost my train of thought for a minute. I was thinking about something else. An inguinal hernia. And it's usually, this is what happens during uteral. And usually what it is, it's where the abdominal wall has a weak muscle and the intestines kind of juts out a little bit so that there's a little bit of a bulge there. It's usually not painful. It says that 1/3 of the babies have this, and generally speaking, this the bulge in the groin or the scrotum, whichever it is, may be seen during crying or straining. It can get smaller and go away when the baby relaxes. It's not tender, and the diagnosis is usually made by just looking at it. It can be reduced. So by putting a finger on the bulge, one will feel the ring under the skin and can push it back down. When it can no longer be reduced, it gets incarcerated, and we take that risk of the intestines twisting and becoming incarcerated. So the baby at the same time will show symptoms of irritability and vomiting, but it needs to be repaired instantly whenever it cannot be reduced. The crypticism is undescended testicles. It can be one or both. And so you always check to see if they're in the scrotum or if they're up high. If they're up high, generally speaking, they'll probably descend by the time the baby's a year old. Some will go up and down and then usually stay down by the time the baby's a year old. If they don't, or you can't find them, a surgery needs to be done, and it's called an orchoplexic. Ambiguous genitalia is where the infant's external genitals don't appear to be either male or female. So genetic and hormonal levels are drawn, and the baby in general will be made to be whatever the hormones have decided this baby should be. Astropia of the bladder, pretty interesting. I've seen a couple astropias, and it's problems with the way the bladder forms, and the bladder muscles don't develop properly for children, these children. The bladder, let me get you exactly. It's a condition where the bladder and parts around it form outside of the belly. The skin, muscle, and pelvic or the hip bones at the lower part of the belly or abdomen are not joined. So as a result, inside of the bladder pokes outside the belly. Instead of its normal round shape, the bladder is flat. And there are also some problems with the abdominal muscles and the pelvic bones. So it occurs, not real frequently. Let me see if I can get you a number on that. Oh, I don't have it. I thought I did. But generally speaking, sometimes it's noted in utero during an ultrasound, and if that's the case, then as soon as the baby is born, the baby goes to surgery, and the first reconstructive surgery begins. If it's not, then the baby needs to be seen by a surgeon. They put a protective covering over the bladder and whatever else is sticking out so that it doesn't get infected, especially with stool. And the baby will go to surgery shortly after the day he's born. First, they just close up the bladder and the urethra and the pelvis. That's the first one that's done immediately. And then the second surgery is done around 6 months. And then when the bladder is grown large enough, and when they're worried about potty training, and unfortunately it's not till the child's about 4 or 5, surgery on the bladder neck is done. So it's the child is slowly repaired over the period usually of about 5 years. Sometimes it needs to be repaired again when they're a little bit older to rebuild or make the outer sex organs look a little bit more unique. Testicular torsion. Testicular torsion is a very painful thing for guys, and this usually happens to athletes. It's where the testicle rotates on the sperm cord and it twists, and it can obstruct the circulation to the testes. The left is affected more than the right because there's a longer cord on the left side. There'll be severe pain in the scrotal area, and it can become cyanotic very, very quickly. So it needs to be repaired as soon as the patient realizes what's going on. It's common with, I think, football injuries, and it will need to. And actually, if it's not repaired like almost immediately, the young man can be rendered sterile. Phimosis is a narrowing of the prepudal opening of the foreskin that won't allow retraction of the foreskin over the penis. It's so narrow. It can cause pain if one tries and it's not ready, and it can lead to infection. What happens is when the child urinates, the urine goes under the skin, and you'll see a bulging of the foreskin, so it will need to be repaired. Okay, a variceal is a painless collection of dilated, and they call it tortuous veins in the plexus surrounding the sperm cord in the scrotum. It can be asymptomatic, or the child may have a dull ache or fullness of the scrotum when he stands up. A palpable variceal has the texture of a bag of worms and may become fuller with bearing down or in a Valsalva maneuver. Unfortunately, this is associated with infertility. They actually just observe this, that there's no clear guidelines on how to take care of a child with this situation. Okay, so I really recommend on the diseases we talked about in the beginning, the disorders, that you do a chart and write, what's different about each one so you can keep them straight. That's usually everyone's hardest, part of this. The structural anomalies, you can read a little bit about it, just know what they are. And that concludes this lecture.